Hi everybody. Welcome to Anatomy with Dr. Rabbit-Heart. I'm Teresa Patitucci, a medical educator and anatomist at the Medical College of Wisconsin. In this video, we will discuss the gross anatomy of the brachial plexus. By the end of this video, you should be able to describe the components of each level of the brachial plexus and describe the coarse, motor, and sensory innervation of the branches of the brachial plexus. Finally, you should be able to apply your knowledge of the brachial plexus to identify patterns of deficits resulting from injury or lesions. Here's an outline of the topics we will discuss in this video. The Roman numerals here correspond to the Roman numerals in the upper left-hand corner of each slide. In the upper limb, motor and sensory innervation is taken care of by the brachial plexus. Brachial refers to the arm, and a plexus means a network. The brachial plexus begins in the neck from the level of the cervical spine and moves through the axilla into the upper limb. These nerves then weave together and finally form 5 terminal branches, which are responsible for motor and sensory innervation of the whole upper limb. The brachial plexus can be broken down into sections. Basically, every time the nerves trade individual fibers around, the section gets a new name. These sections are roots, trunks, divisions, cords, and branches, and we'll discuss more about each level in the next few slides. So let's build the brachial plexus from the beginning. Spinal nerves carry motor and sensory information from the spinal cord to the body. They exit the vertebral column between adjacent vertebrae and divide into ventral and dorsal rami. The brachial plexus begins with the roots, which are the ventral rami of spinal nerves C5 through T1. Some of these roots then converge to form trunks. C5 and C6 combine to form the superior trunk, while C8 and T1 combine to form the inferior trunk, and C7 just continues without merging with anything as the middle trunk. Then the trunks trade fibers around. Essentially, each trunk splits into 2 divisions, with each trunk sending some fibers anteriorly and some posteriorly. Note that the divisions lay superior to the clavicle and may be difficult to see in lab without removing a section of this bone. The next level of the brachial plexus is the cords. The lateral cord is formed when the anterior divisions from the upper and middle trunk merge, while the medial cord is the continuation of the anterior division from the lower trunk. The posterior cord is formed when all 3 posterior divisions merge. Note that the cords are named according to their relationship with the axillary artery, where the posterior cord is posterior to the artery, and so on. Finally, the cords split to form the terminal branches of the brachial plexus. Posteriorly, the posterior cord splits into the axillary nerve and the radial nerve. Anteriorly, the musculocutaneous nerve is a branch off the lateral cord. Medial and lateral cords both contribute fibers to form the median nerve, and the ulnar nerve comes off the medial cord. Note that the musculocutaneous, median, and ulnar nerves together form the shape of the letter M, laying anterior to the axillary artery. Let's zoom out for a second to appreciate the course of the brachial plexus through the neck, axilla, and arm. The roots of the brachial plexus emerge from the lateral neck and are ventral rami from spinal nerves C5 to T1. Trunks and divisions lay superior to the clavicle. Divisions give rise to the medial, lateral, and posterior cords, which surround the axillary artery. Finally, the cords form the 5 terminal branches: the axillary, radial, musculocutaneous, median, and ulnar nerves. Let's pause to check your understanding of how these levels are related. Damage to the medial cord of the brachial plexus would affect function of which terminal branches? Feel free to pause the video to think. The correct answer is D, median and ulnar nerves. The medial cord contributes to both the median and ulnar nerves, so damage here would affect motor and sensory function for both nerve distributions. Note that the median nerve also receives fibers from the lateral cord and can still be functional. Now let's take a closer look at the terminal branches. In this image, we can see the entire course of all 5: musculocutaneous, median, ulnar, radial, and axillary nerves. Notice how the 5 nerves spread out to supply the entire upper limb with minimal overlap. Each nerve has its own domain it needs to cover, weaving their way through muscles to initiate motor movement and out to the skin to mediate sensation and autonomic functions like sweating. Now we will examine these branches one by one. First up is the musculocutaneous nerve, which comes off the lateral cord and immediately pierces the coracobrachialis muscle to innervate muscles in the anterior compartment of the arm. So each time the nerve passes through a muscle, certain motor fibers are dropped off in that muscle while others continue on to the next structure. So by the time the musculocutaneous gets through all the muscles of the anterior compartment, it has no motor fibers left to give and continues on as a purely sensory nerve, the lateral antebrachial cutaneous nerve. The musculocutaneous nerve innervates all 3 muscles in the anterior compartment of the arm, including coracobrachialis, biceps brachii, and brachialis. The terminal branches of the brachial plexus also bring sensory information from the skin back to the central nervous system, and each have their own regions to cover. The musculocutaneous nerve innervates the muscles I just listed and then emerges as the lateral antebrachial cutaneous nerve to bring sensory information from the lateral forearm. Now let's talk about the median nerve. The median nerve gets fibers from both the medial and lateral cords and heads straight down the arm through the inner part of the elbow and then passes through the middle of the carpal tunnel and into the hand. The median nerve does not innervate any muscles in the arm. Instead, it innervates most of the flexors in the forearm, with the exception of flexor carpi ulnaris and half of flexor digitorum profundus, which are both innervated instead by the ulnar nerve. The median nerve also supplies some muscles within the hand, listed here. Sensory information via the median nerve comes from half of the palm, the thumb, and the tips of some of the digits. Next is the ulnar nerve, which comes off the medial cord and then wraps posterior to the medial epicondyle of the humerus and passes into the forearm, where it innervates some of the forearm flexors and muscles of the hand that aren't taken care of by the median nerve. In the forearm, the ulnar nerve provides motor function to flexors not innervated by the median nerve, including flexor carpi ulnaris and half of flexor digitorum profundus. The ulnar nerve innervates most intrinsic muscles of the hand, listed here for your reference. Note that the function of muscles listed in this video will be described elsewhere. Finally, the ulnar nerve carries sensory information from skin over the pinky and half of the 4th digit. Now let's move on to things coming off the posterior cord, the radial and axillary nerves, beginning with the radial nerve. The radial nerve runs along the posterior shaft of the humerus, along with the profunda brachii artery, before entering the extensor compartment of the forearm. The radial nerve innervates all muscles in the posterior arm and forearm. In the arm, this means the triceps brachii muscle. In the forearm, the radial nerve innervates all the muscles in the posterior compartment of the forearm, which work together to extend and supinate the hand. The radial nerve receives sensory information from the lateral part of the arm and a strip of skin down the length of the posterior arm, forearm, and hand. The axillary nerve is the last of the terminal branches and comes off the posterior cord. It diverges from the radial nerve and immediately dives backward to the back of the shoulder through the quadrangular space, along with the posterior circumflex humeral artery. The axillary nerve only innervates the deltoid and teres minor muscles. It also receives sensory information from skin over the lateral shoulder. So let's put that all together. We have musculocutaneous going to the anterior compartment of the arm, so coracobrachialis, biceps brachii, and brachialis. Then we have the median nerve going down to most muscles that flex and pronate the hand, as well as most of the thenar, or thumb muscles. Next, the ulnar nerve also goes to a couple forearm flexors and most intrinsic muscles of the hand, particularly on the medial, or pinky side of the hand. Posteriorly, we have the axillary nerve going to the deltoid and teres minor, and finally, the radial nerve, which innervates the posterior compartment of the arm and forearm, including the triceps and hand extensors. Let's pause to check your understanding. After slipping and falling onto his right arm, your patient comes in with pain and difficulty moving his upper limb. X-rays show a fracture near the mid-shaft of the humerus. He has no issues with shoulder movement, but cannot extend the forearm or hand. Additionally, he experiences tingling over the posterior aspect of the right arm, forearm, and hand. Which nerve was injured in this fall? The correct answer is D, radial nerve. The patient cannot extend his forearm or hand, indicating issues with muscles in the posterior compartment of the arm and forearm, which are all innervated by the radial nerve. This position of the hand is often described as wrist drop. His posterior arm and forearm are also tingling, further indicating an issue with the radial nerve. And finally, the fracture was near the mid-shaft of the humerus, along which the radial nerve runs, and so it makes sense that an injury in this location would affect this nerve. Now we will wrap up by discussing additional small branches of the brachial plexus. Superiorly, the dorsal scapular nerve branches from the C5 ventral ramus and innervates the levator scapulae, rhomboid major, and rhomboid minor muscles. The long thoracic nerve has fibers from C5 through C7 and innervates the serratus anterior muscle from its superficial surface. Due to its location near the axilla and its superficial course, the long thoracic nerve can be damaged during procedures like removal of the axillary lymph nodes during a breast cancer surgery. The suprascapular nerve comes off the superior trunk and passes posteriorly through the scapular notch to innervate the supraspinatus and infraspinatus muscles. The lateral pectoral nerve is a branch of the lateral trunk and partially innervates the pectoralis major muscle. Off the medial cord, we can see the medial pectoral nerve, which can also be found coming through the pectoralis minor muscle on its way to innervate pectoralis major. The medial brachial and antebrachial cutaneous nerves are also branches of the medial cord and transmit purely sensory information from the skin of the arm and forearm, respectively. Finally, there are 3 branches off the posterior cord. The upper and lower subscapular nerves work together to innervate the subscapularis muscle. Lower subscapular also innervates the teres major muscle. The thoracodorsal nerve branches off the posterior cord and travels inferiorly to innervate the latissimus dorsi muscle. Let's pause to check your understanding. Note that this question will become easier as you further develop your understanding of specific muscle actions, which are not covered in this video. Following a car accident where her head was thrown violently to the side, your patient experiences problems moving her upper limb. She cannot initiate abduction or laterally rotate her left arm. Additionally, she has difficulty flexing and supinating her forearm. Which component of the brachial plexus was likely damaged in the accident? The correct answer is E, the superior trunk. In this scenario, the person cannot abduct or laterally rotate her arm, indicating issues with supraspinatus and infraspinatus respectively, which are both innervated by the suprascapular nerve. She also has difficulty with forearm flexion and supination, which indicates an issue with biceps function and therefore with the musculocutaneous nerve. Both suprascapular and musculocutaneous nerves arise from the superior trunk, which is the likely site of her injury. It is important to understand the structure of the brachial plexus and the functions of its branches to determine where lesions have occurred. You can use this slide to quiz yourself about what you would see in a patient with damage to locations of the brachial plexus listed here. Check your understanding of the previous slide here. I hope you have enjoyed this video. If you like my artwork, subscribe to my channel or follow me on Twitter or Instagram at @DrRabbitHeart.